Good morning and welcome. I'm David Merritt, Executive Vice President of Policy and Communications at the Center for Health Transformation. We appreciate you coming this morning. Anniversaries can often be times to celebrate achievement and success, but they can also be times to remember solemn events. And as we approach the one-year anniversary of the signing of health reform into law, it's a solemn time indeed. Over the last year, we've seen reports from independent analysis and from government agencies that show the health reform law will result in higher costs, higher premiums, compromised access, and more government spending. These facts argue for the full and immediate repeal of the health reform law. With us to discuss this morning are three distinguished speakers: former Speaker of the House Newt Gingrich and founder of the Center for Health Transformation, Dr. John Goodman, President and CEO of the National Center for Policy Analysis, and Jim Capretta, who is visiting fellow at the Heritage Foundation and also former Director of Health at the Office of Management and Budget. Each will provide remarks, and then we will hold questions until the end, and we will kick things off with Speaker Gingrich.
Thank you, David, and I want to also join you in thanking two really knowledgeable experts on health. John Goodman has been developing innovative ideas on how to create a better health system, a less expensive health system, a health system with more access for, I think, well over 2 decades. He really was the creator of the health savings account model and developed that entire initiative to try to give people increased resources and increased control over their health. Jim Capretta is extraordinarily knowledgeable in the budget and has a new book that will come out next week. And I think he can really give you a professional insight into some of the really deep budget problems. What happened, as a former legislator, what happened with the Obamacare legislation is really one of the more unusual events in American history. After having been told in virtually every public opinion for months that the country did not want the bill, they lost Senator Edward Kennedy's seat in a special election in Massachusetts in a referendum on the bill. And with losing that seat, they lost their ability to pass a new bill in the Senate. Now, in almost any normal period of American politics and history, a governing group repudiated by the public, having lost the margin, would have stopped, said, okay, we have to be more reasonable, let's rewrite the bill, what is the country telling us? Instead, they did something that was truly remarkable, I think very understudied by most people who've tried to understand this bill. They took a bill which was not designed to be a law. It was designed to be a conference. The Senate version wasn't written to be the final document. It was written to go to conference. And that's why, for example, in the one court test, the judges ruled that the entire bill is unconstitutional because they forgot to write in the severability clause because they were in such haste to simply get it out of the Senate to get to conference with the House, to rewrite it in conference, that the bill's it has a whole series of unusual things, including an entire long-term care provision, which has been routinely described as financially unsustainable, as utterly unworkable, and as extraordinarily expensive. But it was dropped in apparently by some staff person as just an additional, a few $1 billion here, a few $1 billion there. It's already a huge bill. Why not drop something in? So at the center, we tried to take this enormous amount of material and we tried to reduce it to understandable things. And you can see here, this is the third of a series of charts. We have so far, and at the center, I don't think we really planned to do this, but it grew of its own accord. We started out with a very modest 18 square foot chart. And I don't know, do we have that anywhere around here? It's outside. If you get a chance to stop outside, you'll see the original chart number 1, which was simply the 100-plus offices created in the federal government. It's 159 offices created in the federal government by Obamacare, which, when we unveiled it in Richmond, we were reminded by Governor McDonnell, actually understates it because you have to multiply times 50, since many of those offices require a state counterpart in order to deal with the federal government. So if you actually had designed the state and federal offices created by Obamacare, it would have resembled this again. But that was 18 square feet. We then came back and somebody said to us, there are so many deadlines in this bill, somebody ought to just break out the deadlines. And that's is out there behind the registration desk. And that became, just by accident, a 50 square foot chart. We didn't design it that way, but when you wrote out all the deadlines and you tried to make them readable, it turns out to be 50 square feet, which is what this is. We then got in a little bit of an argument with Secretary Sebelius because I said this was a very Stalinist model of centralized control and had vastly too much power in Washington. And she came back and wrote an op-ed in the Wall Street Journal, quoted me by name and said that was a clear misrepresentation of the bill. So we then asked two of our Senator team to actually sit down and read every single word in the bill. And every time they came across a grant of power to the federal bureaucracy, capture that, okay? Well, this chart, if we'd had the nerve, and for budgetary and other practical reasons, David and the team decided it was not appropriate, this chart should actually be 90 square feet because it's almost unreadable. Just to capture this for you for a second, there are 1,968 grants of power to the federal government, most of them to the Secretary for Health and Human Services. Now, one of them, by the way, involves the Secretary determining appropriate inspection of tooth surfaces, which I recently asked a group of orthodontists what they thought Secretary Sebelius's qualifications were for defining nationally the standard for tooth inspection. And they thought the question was verged on just a comment on how much Washington is totally out of control now. So when you look at this, and you can get it on our site, although, again, I apologize, it's hard to read. You can actually buy a copy. It's pretty expensive because it's so big, you have to use very heavy material to make it. But I'll just give you my summary single explanation of why Obamacare will be repealed. No reasonable person, given the track record of the federal government, given Katrina, given the border, given inefficiencies, given all the different things we read about every day, given the fact that we produced a book called Stop Paying the Crooks that showed that the Center for Medicare and Medicaid Services is such an incompetent administrator of your money that we pay 33,000% more as a share of your money to crooks at CMS than you pay as an American Express cardholder. American Express has a 0.03% fraud rate. In New York State, Medicaid is above 10%, more than 330 times or 33,000% more likely. So you take this federal bureaucracy that's clearly not competent to run the current systems, and now I don't think you can go very many places in America and say to somebody, do you really believe the federal government could administer for you personally when you're in a health situation or your loved one's in a health situation, do you really think that 1,968 additional grants of power to the federal government makes any sense? And that's why, if you notice, polls consistently have shown, and a majority of the American people want to repeal this. I think it will be repealed. I think it'll be repealed probably by March or April of 2013. And I think that it's unfortunate that the Obama administration is stonewalling serious rethinking of this bill because in the form it came through and in the way they wrote it, it is clearly an indefensible bill.
Thank you, Newt. During the Democratic presidential primary, almost every serious candidate repeated two words over and over again. They were universal coverage. It was like a mantra. But then when the primary was over, we never heard those words again. And in fact, we really never heard much again about insuring the uninsured. Instead, the entire focus became on insurance industry reform. And the White House asked everybody in the country to mail in their worst case example of a bad encounter with an insurance company. But they didn't want any bad examples about Medicaid. They only wanted bad examples about private insurance, forgetting that for all its faults, private insurance is almost always better than Medicaid. And then leading up to the final vote, all that focused down on really one issue, and that was pre-existing conditions. And every senator and every congressman who voted for the Affordable Care Act had an example of someone in his district or his state that had been discriminated against because of pre-existing conditions. Well, that problem has been solved. As of last fall, everybody in America who is without health insurance, who's been denied coverage because of a pre-existing condition, could buy very good coverage for the same price that a healthy person would pay. And not only has the problem been solved, we even know how many people there are. There are 12,500 of them. Meanwhile, the Secretary has had to grant waivers to 2.7 million workers who are about to lose their coverage immediately because of the provisions of the bill. And those waivers, by the way, are only temporary. Well, what about the other 310 million Americans? How is the bill going to affect them? Well, in just a few more years, the folks at the Marriott Hotel next door to us are going to have an insurance policy whose benefits are defined by the federal government. And best estimates are that for family coverage, it's going to cost about $15,000. And that includes workers who are only making $15 an hour. The maids, the busboys, the waitresses, the custodial people, the gardening people. They're going to have a health insurance policy that's going to cost something equivalent to about half of what they make. And Marriott and the employees are going to get no additional help from the federal government in order to buy this insurance. In fact, the only relief for them is for somehow Marriott to end its insurance altogether, or to fire all the employees, or somehow treat them as independent contractors, or make them all part-time, or put them in a different corporation that doesn't provide insurance. If it does these kinds of things, these employees will make it over to the newly created insurance exchange, where the federal government will pay almost all of the $15,000 premium. And not only that, but for workers at that income level, it will reimburse them for most of their out-of-pocket costs. So according to the Congressional Budget Office, the subsidy for the federal for these employees over in the exchange will be close to $19,000 versus no new relief if they get insurance at work. So what we foresee happening is a major change in industrial organization in the United States, with almost anybody who makes an average or below average income wanting not to get insurance through the employer, preferring to be over in the exchange. And that will cause a restructuring that will not be good for the economy. You don't want businesses to form and dissolve and reform based on health insurance subsidies. You want them to make these decisions based on economics. In addition, the bill locks us all into a path in which the cost of the insurance is going to be rising at twice the rate of growth of our income. And Barack Obama didn't create this problem. Congress didn't create the problem. It's been going on for 40 years. But the new bill makes it very hard to get off the path because it takes away all the normal defenses people would have, going to a higher deductible, going to a more limited package of benefits. You're going to be greatly restricted in your ability to do those sorts of things. The insurance exchange has not been talked about at all, but it deserves lots of attention because insurers in the exchange are going to want the healthy and not want the sick. And that preference doesn't end once people join your plan. So the incentives for the plans will be to overprovide to the healthy and underprovide to the sick. And that'll be good if you're healthy. You'll get extra benefits that you weren't getting before. But if you need serious medical care, it won't be good for you. You don't want to be in a health plan that doesn't want you any more than you want to go to a restaurant that doesn't want you. And yet that's the kind of market that we're about to set up. There are perverse incentives for individuals, and we're seeing this in Massachusetts today. People stay bare, don't buy insurance when they're healthy, pay a fine if they have to, but it's a small fine and not always enforced. Then when they get sick, they enroll, they get their medical care, they get their bills paid, and then afterwards they drop their insurance. Now, the number of people doing this in Massachusetts is rising. It may be a problem that Massachusetts can muddle through with, but in a state like Texas, this would be disastrous. In our emergency rooms, we sign people up for Medicaid right there in the emergency room. If we're signing people up for Blue Cross in the emergency room, Blue Cross is not going to stay in business for very long. Finally, I want to point out that we've made promises that we can't possibly keep. We have 32 million Americans who are going to be newly insured. If the economic studies are correct, these people will try to consume twice as much health care as they were consuming before. Everybody else, or most of everybody else, is going to be pushed into a plan with more generous benefits than they had before. A whole long list of preventive medicine with no deductible, no co-payment. So we're looking toward a huge increase on the demand side. The bill has no increase in supply, however. All the money that was there for new doctors, new nurses, was all zeroed out right before it was passed. So what happens when you have a huge increase in demand but no increase in supply? You have a rationing problem. And when you have a rationing problem, that's not going to be good for people who are in a plan that pays below market. Well, whose plan pays below market? They are the seniors in Medicare, and the disabled in Medicare, poor people on Medicaid, and probably all the new people in subsidized insurance on the exchange. If we follow the Massachusetts example, subsidized insurance on the new exchange will pay rates that are a little better than what Medicaid pays. In Massachusetts today, the wait to see a doctor is longer than any other U.S. city. There are more people going to emergency rooms in Massachusetts today than ever before, and we think that is what you're going to see nationwide. Thanks.
Thank you, Mr. Speaker. Thank you, John. It's great to be joining you at this event. Former House Speaker Nancy Pelosi famously said about a year ago, just before passage of the bill, that they had to pass it to find out what was in it. And I think this chart here, some of the things John has said and others have said show that people are finding out what's in the bill. And the more that is learned, the worse it gets. It is not well understood at the moment how much this new law poses a risk to America's seniors. About $500 billion in the so-called pay-fors that allowed the bill to get passed came out of the Medicare program. The largest reduction was a permanent annual reduction in the payment rates, in the inflation update for institutional providers of care, hospitals and others. And of course, there's an existing in-law reduction in physician services that has not been fixed. These reductions are going to pose a very substantial risk to the beneficiary's access to services, as John was alluding to. Medicare rates are already quite below what a private insurance has to pay to access care. Now with these cuts, they'll go way, way below what private insurance will pay. And don't take my word for it. This has been the consistent message of the chief actuary of the Medicare program for the last year. He's warned the administration about this. He's warned the public about this. In his trustees report last year, issued last August, he had to issue a special supplement to the trustees report that basically said, don't believe any of the numbers in the main trustees report because they assume these reductions will go into effect on a permanent basis in perpetuity. So he issued a separate document that basically said, on an alternative analysis shows that this is not going to happen and that Medicare has actually not been improved at all. Now, the other part of this is that they use this reduction to make the argument that the new law will reduce the federal budget deficit. That was one of the main talking points. You know, not only can we cover everybody, but boy, we're going to reduce the budget deficit too. Of course, if these $500 billion in cuts in Medicare don't materialize, then you haven't reduced the deficit, okay? That's point number one. But there's a number of other things in this cost estimate that leaves one wondering whether it's really gonna work out as planned. Let's start with the one that the speaker alluded to. There's something called the CLASS Act. That's the long-term care program that I would say essentially hitched a ride on the bill. It's not unrelated to the rest of the provisions. It was hooked on to the bill really for one reason only, which was it looked like on paper that it produced $70 billion in deficit reduction that could be used to grease the way for the larger entitlement program. Everyone now, you know, a year after the bill is passed, Secretary Sebelius has suddenly discovered that this new long-term care program is financially not viable, that it's got design flaws such that it will suffer from severe adverse selection. And I would note that this was known well before the bill passed, that everyone who looked at this program in the run-up to passage was warning the Congress that it was designed this way, that it would mainly attract those, because it's voluntary, it would mainly attract those who anticipate they might need the benefit. And so beyond the first 5 years when everyone's required to pay premiums, they will start to lose money in a large way, and it will become unfinanced. In fact, not only does this not pay for the bill in any real sense, what it does is it sets the predicate for another federal bailout. Because the only way to make the program solvent is to renege on the benefit promises to those who sign up, make them pay exorbitant premiums, or go to general taxpayers and ask for a bailout. So they've greased the way for a very large entitlement expansion through the creation of a program that itself will need a bailout down the road. Let me also just note that The employer situation here is pretty serious. This program establishes a new entitlement for people between 133 and 4 times the federal poverty rate. That's a big group of Americans. According to the census data, the number of Americans in that income category is upward of about 110 million people. The current cost estimate assumes only about 20 million of them will end up in the new subsidy, in the new entitlement program through the exchanges, because they assume the employer-based system will remain perfectly intact. But as John made the point, that creates tremendous disequilibrium, a lot of inequity. People living right next door to each other getting much more subsidies through the state exchange systems than they do through the employer-based system. Over time, the entitlements have always had one effect, which is people find their way to them. Employers and their workers would be better off if the workers were getting this massive new entitlement. And Doug Holtz-Eakin, a former CBO director, has looked at this and said, if just the people below 250% of the poverty line ended up in the exchanges and left the employer-based system, it would add $1 trillion to the cost of the bill. So there's a huge upside risk in terms of the cost here. Finally, let me just note that what a tax increase this was. Yes, it was disastrous for the budget. It's bad healthcare policy. It will lead to arbitrary cost cutting and irrational resource allocation in our health system. But it also was a massive tax hike, and it's bringing back what people thought we had gotten rid of with President Reagan, which was bracket creep. Essentially what they did was they put in place a new payroll tax for Medicare, and they said it was only applied to people who are rich. And the definition of that is people making more than, with an income above $200,000 a year for singles and $250,000 for couples. Those brackets are not indexed for inflation. So over time, everybody in America will eventually be paying this. If you allow 20 years to go by and inflation to occur, especially the way we're pumping money into our economy these days, a lot more people will end up with that kind of an income. And when that happens, the revenue hike will be very substantial. They claim a lot of deficit reduction in the second decade from this bill. Most of it comes from this kind of bracket creep. CBO has looked at the cost estimate for this over a 2-decade period, and they said by 2035, we'd have a 1.2 percentage point of GDP tax hike just from the tax provisions of the health law. You can imagine what that'll do to our economy and growth. I think I'll leave it there and we can move on to questions. Thank you.
Sure. One thing I'd also mention, out on the registration desk is a USB drive that has a lot of the materials, has electronic copies of all of these charts, as well as reports from all 3 organizations. So I do encourage you to pick that up on your way out. Yes, sir.
Just a comment.
Could you please...
My name is Alan Fritz from Fairfax, Virginia. The Medicare system is broken right now, as you're probably well aware. Right now, a person on Medicare, when he goes to a doctor providing Medicare, has to pay a concierge fee in most states. And that concierge fee in the state of Virginia is $45 per visit. I'm sorry.
Just talking.
Okay. And that concierge fee is $45 per visit to a doctor that's providing Medicare. Now, I was surprised at this, but then my wife was in Tennessee and was told that it's been going on there for a year and a half. That there are concierge fees now that doctors are providing, and simply because Medicare is not being reimbursed adequately. Doctors providing Medicare are not being reimbursed adequately for the care they provide under Medicare. As one of your speakers said, the private insurance does adequately pay for treatment, but the Medicare program does not provide doctors sufficient reimbursement.
Dr. Goodman's actually studied this issue on the supply side in Medicare and can certainly comment.
Well, I totally agree with you. And the way this bill, the Affordable Care Act, is financed is by reducing further payments to doctors and hospitals under Medicare. In fact, over half the cost of the bill is paid for by reduced spending on seniors. What the chief actuary of the Medicare program says is that the rates paid to doctors and hospitals will continue to decline, and before this decade is out, Medicare will be paying less than Medicaid. That means that seniors on Medicare will be less desirable in terms of what they're paying than welfare mothers. And then it just keeps getting worse year after year, decade after decade. It just falls further and further behind what everybody else is paying. Now, Joe Newhouse, who's a health economist at Harvard and probably even a supporter of the Affordable Health Care Act, wrote in Health Affairs that everybody who can afford to do so on Medicare will probably be turning to the concierge doctors. And everybody who can't afford to pay those concierge fees will probably be where Medicaid is today, which means at community health centers and safety net hospital emergency rooms. So you're right on.
Next question. Yes, ma'am.
Jessica Zygmunt with Modern Healthcare Magazine. I open this to the panel, but maybe we could start with Mr. Speaker and move on down. Democrats have criticized Republicans for wanting to repeal the law, but not really offering anything substantive in the way of replacement and reform. Could you just cite one or two examples of where you think Republicans should start addressing healthcare reform?
Sure. Well, I mean, on behalf of David and the Center, I'll just start by saying if they go to healthtransformation.net, they'll find layer after layer of initiatives that would be helpful. One example, which fits Dr. Goodman's point about the supply of doctors, is to have litigation reform as a very high value. We did a study last year at the Center for Health Transformation with Gallup and with Jackson Health, which has connectivity to about 400,000 doctors. And they got back an estimate that defensive medicine today, this was doctors themselves estimating how many unnecessary tests, how many duplications, how many things are done out of defensive medicine, could be as high as $800 billion a year. And the threat of litigation is a major factor in people not going to medical school. So if you start with the gentleman's concern, you either have to have a lot more doctors or you're going to have a lot of people in long waiting lines if all you do is increase demand without increasing the supply. And so that's a part of it. We are working on a proposal that we'll have in a few weeks to block grant Medicaid. We think at the Center that it's obvious, and this chart reinforces it, the federal government, the experiment in federal micromanagement of health care for the poor nationwide is clearly a failure. It is too expensive, it's too cumbersome, it's too bureaucratic, it is riddled with fraud, and we don't believe the federal government can fix it. And I've been going around the country talking to state legislators and governors and state health officers about a very fundamental block granting of Medicaid back to the states to allow them to run parallel experiments to see what is the best way to provide health care to the poor and to get the best health outcomes at the lowest cost. I think you want to have both. You want to have the best outcomes. It's never a money-only provision. You have to tie outcomes to money because health is a moral issue and you're actually trying to take care of human beings so that they have longer lives with greater independence. But John, do you want to comment?
Let me just briefly say, people who say Republicans have never offered comprehensive alternatives have short memories. During the last presidential election, the most important issue was health care. And the most important health care issue was not Barack Obama's health plan, it was John McCain's health plan, which was basically the Coburn-Ryan bill. And Barack Obama probably spent more money attacking that health plan than has ever been spent on any single public policy proposal in the history of the Republic. Tens of millions of dollars in TV ads. Then turned around and, of course, adopted many of the things that McCain was for. But basically, the Republican approach in the election was to give everybody the same tax relief, regardless of where you get your insurance, whether you get it at work or in the marketplace or in exchange, and to adopt some sense of fairness so that you don't give 60 or 80% of the money to the people in the top 20% of the income distribution. So there is an alternative. Republicans are a little skittish about trotting it out given all the demagoguery of the last election. But I think if there was some serious effort on the part of both parties to go back to the bargaining table, we could have a much, much better health reform result.
Jim, do you want to comment?
I think that's enough said there.
Okay.
Stephanie Kirchgesner with the Financial Times, a question for the Speaker. Do you, as a principle, believe that the law should protect people who have pre-existing conditions from having insurance? And if so, what's a real feasible way to pay for that?
Well, I
absent
think
the individual mandate.
Well, I think first of all, people who get insurance should be protected from losing the insurance if they have a pre-existing condition. But you have to design it carefully because what you can't do is you can't set up a system that encourages people not to buy insurance until they get sick. I mean, imagine if you had a house insurance policy that people only took when their house burned down. Now, everybody understands psychologically, it doesn't take much mathematics to figure out, no insurance company in the world could have a post-fire insurance program. So if you say, can you adopt a law that says once you're in the insurance system, you can transfer to other insurance companies, you can change jobs, you're guaranteed that if you get a pre-exist, that they cannot stop you from being insured because of pre-exist. That's actually actuarially fairly easy to do. But you can't do that for people who refuse to buy insurance. And remember, a substantial number of the people who don't buy insurance are young and relatively well off. They're making an economic gamble. And then they're basically saying to their neighbors, if I show up in a motorcycle wreck and I end up in the emergency room, even though I'm uninsured, I'm sure you're going to pay for it. Now, there's something wrong with that, and I think you have to think through how you deal with it. John had a proposal, I don't know if you want to go into it, one time where you would have a tax credit to buy insurance. If you refuse to buy insurance, which is your right, that tax credit would then go into an uninsured fund, and you'd be dealt with, but you'd be dealt with as part of an uninsured fund. And I want to draw a distinction that seems very politically unpalatable to many people. It's much easier to guarantee access to care than it is to guarantee insurance. You can design a system that pays for emergency rooms. You can design a system that pays for community health centers. You can guarantee that virtually every American gets care. What gets expensive is if you start trying to guarantee that every American is going to go to the most expensive place in America for the most expensive treatment at their convenience when they feel like it. That's very expensive to create. But I think we could guarantee that people would have access to care dramatically easier and with much less complexity than Obamacare. Do you want to comment just on your model that you'd built?
Well, I'll do this very briefly. Let's say we offer every family in America $7,000 refundable tax credit, which I think we could easily do. And so if you buy insurance, you get the $7,000. I wouldn't tell you what insurance you have to buy. I would hope the $7,000 covers the core insurance we want, catastrophic insurance we want everybody to have. Any additional insurance you pay for with your own money, with your employer's money, but without any tax subsidies. But if you turn us down, you decide to be uninsured, as Newt said, we take the credit that would have gone to you and we put it in a safety net. So we're not going to let you go without care. And that safety net is not going to be as attractive as private sector medicine. But the government makes a commitment to people. You want insurance, we'll put the money there. You want to be in the safety net, we put the money over in the safety net. That seems to me to be a fair, rational way for the federal government, a rational role for the federal government.
If I could just say one or two words about this, I think that it's very important that people understand that the kind of proposal John has outlined is actually a universal coverage plan. That if someone forgoes the tax option that he's put on the table, then they lose insurance. But very few people would actually forego several $1,000s of a tax break if they could get some kind of insurance from that. So in some ways, I think what Senator McCain proposed in the 2008 campaign was mischaracterized very badly. It was a universal coverage plan, and in fact, probably more so than what was passed in the law last year. There's going to be a lot of gaming of the individual mandate to such an extent that insurance coverage under the new law may be way, way worse than people are currently expecting.
Thanks. John Ward at the Huffington Post. I'd like to hear from the speaker, but could open this up to the panel as well. You've talked about, or you predicted that you think that the healthcare law would be repealed in early 2013. That presumes, obviously, that President Obama was defeated, which is obviously something that you maybe like to be a part of. But if that does not happen, what is your analysis at this point of the chances for something to happen legally in the courts and the Supreme Court for the law to be overturned?
I'm not a lawyer, and I can't tell you. I also find it very difficult to project sometimes what the court will do. I think the fact that you had two judges say that it was the mandate was unconstitutional, and the fact that one of them pointed out that in the absence of the severability clause, traditionally, that means the whole bill could be knocked out, puts the bill at risk. But whether or not by itself that leads the court to declare the whole law unconstitutional, I have no idea. As a general principle in America, we have very few examples of a reform which has been opposed by the American people which survives. I mean, over time, the sheer weight of public opinion, it's one of the good things about our country, the sheer weight of public opinion consistently forces the system to ultimately follow the people rather than the other way. And I think in that sense, you'll see, frankly, an enormous mess. If the bill's not rejected by the courts, the fighting between the Republican House and a growing number of Republican and Democratic senators who are disaffected by this, the more things that are surfaced, and the Class Act is a good example. I mean, when you realize how totally impossible it is to fund that provision, it's very hard to see how it's going to survive. And so what you currently have is administration running around trying to defend the indefensible. And I just think at some point that psychologically starts to break down. And so the best you're going to get is a real mess from the standpoint of the left. And the worst you're going to get is total repeal. And I think you don't know yet. Could you get that by the courts between now and then? Yeah, I mean, you could. I wouldn't, as a strategy, I wouldn't count on that, but that's a possibility. You want to comment on the legality?
Well, let me just make a quick point. And this isn't my area of expertise, but even if there were no Republicans in town, I think Democrats are not going to want to let this law go into effect in 2014 the way it's now written. They're going to want to reopen it because of some of the problems we're discussing here. When they do that, if they're smart, they will bring Republicans to the table and try to get agreement on something that both parties want going forward. Because if they don't do that, then Newt's absolutely right. It's not going to survive.
We have time for 2 more questions.
Nicholas Ballasy with CNS News. Question for the Speaker. Mr. Speaker, you were a prominent supporter of the Medicare prescription drug plan that President Bush signed into law in 2003. The Medicare trustees now say that plan is $7.2 trillion in unfunded liabilities over the next 75 years. Do you regret your support for the plan looking back?
No. I think that I am for dramatic reform of Medicare. I chaired the Medicare Reform Task Force, which saved it in 1996 when the trustees said it was going to go broke. And we passed changes which enabled them to say that we had postponed any problem for well over a decade. And I'm very prepared to talk about how to reform Medicare and make it economically viable. But I feel strongly that the number one purpose of healthcare is health. And Medicare was designed in the 1960s when pharmaceutical drugs were not a significant part of how you took care of people. And for us to have a government-run health plan that said, we're not going to help you with insulin, but we'll be glad to pay for kidney dialysis, is an utterly anti-human provision. And so all I was in favor of was modernizing the system to recognize modern medicine. We spend $29 billion a year now, $27 billion a year now in kidney dialysis. So my counter in part would be the right application of modern medicine for the right prevention, the right wellness, and the right management of chronic conditions actually makes the system much less expensive. But that means you've got to take the totality. If all you do is count the cost of insulin, then it's an increase. If you count the ability to avoid or defer kidney dialysis, it's an enormous improvement. And I think we have to look at the system from that standpoint.
Last question.
Steve Thoma with McClatchy Newspapers. You were talking about repeal in 2013. As you know, there are a lot of conservatives, particularly in the House, who want to vote right now, particularly to strip out the appropriations. What do you make of that? Should they vote now to do that?
Well, I publicly advocated and sent a letter to the Rules Committee in favor of Congressman Stephen King's proposal to defund it, and that's going to be one of the challenges that the Obama administration is going to face. I don't see how they force the House to pass appropriations this year to implement the bill. I mean, the president would have to go to the country and say, I'm now going to veto this bill on behalf of more spending for a bigger deficit with a bigger Washington bureaucracy for a bill you want repealed. I think that is a pretty losing political proposition for the president. And I suspect the House Republicans will, in fact, defund the Obamacare. They've already passed by a significant margin repealing Obamacare. It's obviously not going to get to the president. He would veto it. So he can block them from repeal. I don't think he can coerce them into funding. And I think that Speaker Boehner and Majority Leader Cantor are absolutely committed refusing to fund the implementation of Obamacare. And I think as you watch Congressman Ryan roll out his budget in a few weeks, you're going to see how really bold and really dramatic they're prepared to be in fundamentally changing things. And I think they're likely, for example, to come out for block granting Medicaid, which clearly is a fundamental replacement of Obamacare. And so I think you'll see the House Republicans very, very tough about stopping the implementation.
Thank you very much for coming this morning. I know